Well, good morning to everyone. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll get started with a few announcements as this is our first session for fall of 2023. A few quick reminders. Next week, we will be hearing from Dr. A.J. Singhvi, who will be giving the talk Pancreatitis, Choledocholithiasis, and Cholangitis, an endoscopy perspective. A few logistics to remind everybody. I'm really excited about the 2023-24 Grand Round season, which is a joint effort between Providence St. Vincent Medical Center and Providence Portland Medical Center. The Teams Live platform has given us a great opportunity to expand our viewership, but we are also very excited to be back in person when possible. The weekly invite for Grand Rounds will always indicate if we will be only virtual, and Grand Rounds will always remain available virtually on Teams Live, or if we will be here live in Southern Auditorium at Providence St. Vincent and occasionally live at Providence Portland, particularly when we are hosting visiting speakers. You, of course, can earn CME credit for attending Grand Rounds. You can be here with us in person, live virtual, or you can watch a recording of the session. And those recordings are the same link as the invite to Grand Rounds. I'll be monitoring the Q&A throughout the session today, so please speak up here in the room or post your questions or your comments on the Team Live Q&A. I'll mostly hold those till the end to ask our speaker as time permits. And now I am particularly excited for today's introductions. Today is the annual Jeffrey Cleven Lectureship sponsored by the Portland Clinic. Established in 2018, the intent of this lectureship is to bring an exceptional educational program with particular emphasis on lifelong learning and support of high-value care. Dr. Jeffrey Cleven, who we have the good fortune of joining us today at Grand Rounds, joined the Portland Clinic in 1977 and in 1994 was named the Chief Medical Officer, where he was instrumental in the clinic's focus on the triple aim of access, cost effectiveness, and quality outcomes. This lectureship honors the long-standing relationship between Providence and the clinicians and leaders of the Portland Clinic. Dr. Cleven's weekly Grand Round attendance, which continues to this day, is just one testament to his passion for lifelong learning and dedication to excellence in the care of his patients. Thank you for your care of our community and for joining us today, Dr. Cleven. And now to introduce today's speaker, we are joined by Dr. Doug Powell, Professor of Medicine and Primary Care Internist, who serves as Director for Student Teaching for the Department of Medicine at the University of Washington. Dr. Powell earned his medical degree from University of Michigan Medical School and then went on to do primary care internal medicine residency at the University of Washington, where he also served as chief resident at Harborview Medical Center. Dr. Powell has been on faculty at the University of Washington Medical Center since 1989, and I just recently learned, in fact, worked with one of our own faculty, Dr. Alex Schaefer, when he was a resident at University of Washington. So it all comes back around. Dr. Powell has earned multiple teaching awards, including Distinguished Teaching Award for the University of Washington in 1997 and the Distinguished Teaching Award for the School of Medicine in 1993, 4, 5, and 7, at which point he was elected Teacher Superior in perpetuity for the University of Washington School of Medicine. He has also received the Robert Glazer AAMC Distinguished Teacher Award in 2001. Dr. Powell remains extremely active with the American College of Physicians and was governor of the Washington State ACP chapter. Dr. Powell also served as AOA counselor at the University of Washington since 1994 and is currently serving as national president for the AOA. Truly a master clinician and teacher. We are so delighted to have Dr. Powell join us today for our Cleven Lectureship.
Thank you, Laura. And can everybody hear me okay? Great. I'm a little hard of hearing, so I'm very sensitive to that. So I'll try to speak loud and try to speak as clearly as I can. I really am honored to be here with all of you and to be able to share and teach. And what a wonderful testimony, Dr. Cleven, to have this to help educate others. And one of my great passions in life has been the whole issues of what I call medical myths. And I really think it's more dogma than anything else than really medical myths. Let me see if I can get this going. And what I'm going to try to cover are things that maybe evolve over time, but maybe we were taught in our training one way, and with somebody teaching us saying, this is the way to do it. And my whole take on this is whenever anybody's so certain something's right, they're probably wrong. You know, that the reason I became an internist is there's so many pathways to the right answer in internal medicine. You know, you have to be rational, you think through things carefully, you have a good reason, and you watch carefully at all the information that comes back to you and you adjust your plan. The idea that there's only one way to do things usually is not the case. So many of these you may have been taught there's one way to do it. So why do these things happen? Well, sometimes it's physiology that just makes too much sense. A lot of times case reports that get into articles and they get in textbooks, but they don't get the same scrutiny as randomized controlled studies. And then tradition, which is just, this has never been studied before, but it must be right. And so we'll talk about some of these myths and how they came about. So I'm going to start with some really old myths. So I do this when I speak on this because many of you might have gone, oh yeah, that's so 1980s. But occasionally people will be surprised by some of the stuff, and I try to go through some of the data behind these. So here's our first case. An 82-year-old woman is evaluated for fatigue. Her lab reveals hemoglobin of 8 with an MCV of 114. Her B12 level is low at 90. Her folate level is normal. Urine methylmalonic acid level is high. What would you recommend for this patient? Oral B12 1,000 micrograms a day, blood transfusion, then IM B12 monthly injections, or IM B12 load, then monthly B12 injections. So how many of you, and let's have you all participate, raise your hands when you find what you would do or what you would like to do. How many would choose A, oral B12 1,000 micrograms a day? How about a blood transfusion, then B12 monthly? How about IM B12 load and then monthly B12 injections? Good, so most of you are going to go ahead with oral replacement of B12, which I think is the right answer here. The dogma that was taught, and it's been in many, many medical textbooks, and even until 20 to 25 years after the data was known, it remained in medical textbooks, was that you must have intrinsic factor absorb B12, and that people with pernicious anemia lack intrinsic factor, so they can't absorb B12. So why would you give anything orally if you don't have something that will help you absorb it? That was the thought. Well, the first study that really was well done and was, really pretty powerful study. It wasn't a huge study, but everybody in the study did great. It was from 1968, 64 patients with established B12 deficiency from 3 Swedish medical centers, a lot more pernicious anemia in Scandinavia. So this was not a uncommon problem there. They got 500 to 1,000 micrograms daily, and all 64 normalized their hemoglobin hematocrits. They followed them for 7 years. Nobody got neurologic disease. Everybody did great on oral B12. This should have solved the problem of what do we do with pernicious anemia back in the 60s, but certainly in the 1980s, when I was a medical student, I was taught you give IM B12, and then I watched that unfold through my career of many people on IM B12, and I still get patients that have been on IM B12 for 5, 10, 15 years. So in the 1990s, this was restudied. This is a study that was published in Blood. It was the 90s, everything has to be bigger and better. 1,000 proved to be fine. Well, what the hell, let's give them 2,000. So 2,000 of oral B12 a day, and compared them to people that were getting B12 injections, and the levels actually were higher in the oral supplementation group because they're given so much B12, and they got up to 1,000 picograms per milliliter compared to 325 in the IM group. So both groups did fine. They normalized hemoglobin hematocrits, but there was actually higher B12 levels in the groups that got the 2,000 orally. Question that comes up a lot is, okay, that's fine if the issue is intrinsic factor. How about if you're missing your stomach? How about you've had a gastrectomy? Can you give oral B12 to them? This is a small study that looked at that question, and they gave everybody 1,000 micrograms of B12 for people that had gastrectomy. They followed them for up to 20 months. Everybody had normal B12 levels, and they felt that it's a fine option for gastrectomy patients. The nice thing about if you want to try oral B12 in any situation of B12 deficiency is we can follow levels. We can see if they absorb it. So if you go, well, they got part of their bowel removed, but maybe they have enough to absorb it still, you can follow levels. So there's no danger to trying oral B12 therapy, and I think it's much easier for people. The cost is cheaper than I am, and it's easy to do. Cochrane 2018 review said that it works. There aren't a lot of studies, so they called it low quality evidence, but all the studies that have been published all had pretty much 100% of the patients succeeded with oral B12. Now, the reason it works is you need intrinsic factor for the amount of B12 you get in your diet. We don't get that much B12 in our diet, but we're very efficient at absorbing it because of intrinsic factor. But there is some absorption through mass action. So if you put a massive amount of B12 through 1,000 or 2,000 microgram tablets, you will get anywhere from 1.5 to 3% absorbed through mass action, and that's why people get such high levels with the oral B12. Questions always come up, do you need the sublingual B12 that's sold? No, it's absorbed orally. You don't really need to do it sublingually. It's available, but most of that absorption is also swallowed in oral absorption. Okay, let's try another one. A 32-year-old man is diagnosed with Giardia and prescribed metronidazole. He has no other medical problems. He will be the best man at his brother's wedding tomorrow. What advice should you give him about alcohol use at the reception? Do not take metronidazole the day of the wedding if you will be drinking alcohol. Take metronidazole, do not drink alcohol. It's okay to drink alcohol. So what do you advise him? He's just started on some metronidazole for Giardia. How many of you would tell him, don't take the metronidazole on the day of the wedding if you'll be drinking alcohol? How about take metronidazole, don't drink alcohol? How about it's okay to drink alcohol? Yeah, so the answer I think is C. I think that's the right answer. And let's go through this. This is still on every bottle of metronidazole you prescribe. There'll be a little martini glass with an X through it. And it'll be put on lovingly by the pharmacist. That sticker will be put on, and they will counsel the patient not to drink alcohol when they're taking metronidazole. And the reason for that was a belief that metronidazole could cause a disulfiram-like reaction when alcohol was taken in. This is the standard wording that to this day is still on pill bottles of metronidazole, pretty much accepted as a proven reaction. Where did this come from? Well, this is a case reports one. So there are case reports from very early on that said, gee, my patient was on metronidazole, they drank some alcohol, they got nausea, vomiting, felt a little lousy, felt horrible. Must have been an interaction. Well, I think people can do that with alcohol alone, and I think people can do that with metronidazole alone too. Metronidazole is not the greatest drug in the world for feeling wonderful, but the idea was that the two together were really, really bad. And there was one fatality case report, and that's a really interesting case report to read because the patient had been clubbed over the head and had a massive head bleed, but they decided the death came from a drug interaction for the two, including the fact the patient was not prescribed metronidazole seemed to not dissuade him from that. So case reports can be pretty sketchy as far as long-term evidence and information. They're wonderful for alerting us to things we need to watch for and then hopefully study in the future. So are there any possibilities that this interaction could actually happen? And the answer is yes. There is a possibility that in the gut, acetaldehyde levels could go up. And this has been studied in rats, and in rats, intracolonic acetaldehyde levels can go up, blood acetaldehyde levels do not go up, and there is no direct interaction. The idea is that metronidazole can change the microbiome. We certainly know that can happen. It's going to change some of the bacteria in the gut, and rats treated with metronidazole had more Enterobacteriaceae, which is a alcohol dehydrogenase containing aerobe, which can be a problem. So diarrhea, possibly. probably not in the bloodstream and causing problems. So we need a randomized controlled study, right? Okay, we got rats that might be having issues. We have case reports that are rogue. What do? Well, we run a small randomized controlled study. So 12 healthy participants. Where do you think we get 12 healthy participants that want money and alcohol? MedStu, very good. Yes, absolutely. They don't question anything. It's like $300. I'll do an endoscopy on you every 2 weeks for a month. Okay, go figure. I guess, when we're in medical school, we are also incredibly poor. We do whatever. Well, this one wasn't a hard sell because they all got alcohol. Some of them got metronidazole. 6 got metronidazole. 6 got alcohol. They did it well. They gave the metronidazole for 5 days before they gave them the alcohol. That was important because if it is an issue with microbiome, you don't want to just give them a lot of metronidazole and then alcohol and look for a true interaction. They were looking for all signs of it. And what they found is that everybody felt the same, that there was no difference in temperature, any symptoms, pulse, blood pressure, and then subjective symptoms. They measured blood acid aldehyde levels, they measured blood alcohol levels. There was really no difference between the groups. And so this is the one tiny piece of evidence that shows that there really isn't an interaction. Now, interestingly, the CDC is very convinced by all of this evidence, and they put in the most recent STI guidelines. The previous warning against simultaneous use of alcohol metronidazole is based on laboratory experience and individual case histories in which the reported reactions were equally likely to have been caused by alcohol or adverse effects of metronidazole. And then they went through that metronidazole does not inhibit acetaldehyd dehydrogenases, occurs with disulfiram. Alcohol alone, alcohol-independent side effects of metronidazole explain the suspicion of the like reactions. Thus, refraining from alcohol use while taking metronidazole is unnecessary. Okay, a 30-year-old woman cuts her finger on a glass jar. She goes to the ED and needs to have sutures in her right ring finger. What would you recommend for anesthesia to prepare the patient for repair? So this person gets a simple cut. You're going to just put a couple of stitches in. What would you do to numb her up? Bupivacaine, lidocaine 1%, lidocaine 1% with epinephrine, lidocaine 2%, or saline. So which of these would be probably the optimal anesthesia? How many would use bupivacaine here? How about lidocaine 1%? How about lidocaine 1% with epinephrine? How about 2% lidocaine? How about saline? Okay, so the right answer here is, and what the hand surgeons do is C, lidocaine with epinephrine, which is something that I think pretty much everybody in this room was told never to do. It's like, if you want somebody to get a gangrenous finger and get sued, you put lidocaine with epinephrine in a digit, put in a digit or any end arterial field. And that was the conventional wisdom that we were all taught, been in many, many emergency medicine textbooks, primary care textbooks. And so this was something we just didn't want to do. Well, back in 2001, there was a very small randomized controlled trial, 60 digital block procedures, 31 randomized to lidocaine with epi, 29 to lidocaine. Lidocaine with epi, 1 patient needed additional anesthesia, lidocaine alone, 5 needed additional. So the epi actually kept the lidocaine active longer, so they needed less additional anesthesia. But more importantly, there was less bleeding with the lidocaine with epi, which is what we would hope for. It was only needed, a digital tourniquet was only needed in 9 of 31 patients in the lidocaine with epi group, 20 of 29 in the lidocaine alone group with a good p-value, and the complications only occurred in the lidocaine with a lone group. So lidocaine with epi, there were no complications. Tiny study, not going to move the needle for most of us, but it's interesting, right? So let's go ask all the professionals what they do. So this is a study of hand surgeons looking at what happened to thousands of their patients who got lidocaine with epi. So they prospectively looked at the incidence of digital infarction, phentolamine rescue in a large series of patients who got epinephrine in their fingers and hands. From 2002 to 2004, 9 hand surgeons recorded each injection of epinephrine in the hand that they did. 3,110 consecutive cases of elective injection of low-dose epinephrine in the hands and fingers. No cases of digital tissue loss. Phentolamine was never needed. So this is pretty much what all hand surgeons use. They're super comfortable with it. But still, for most of us, we've been taught one way and we haven't really been that hasn't been changed. So I've been speaking on this for a while, and podiatrists have been in the crowd, and they've come up, they go, we've been doing this for decades. We've been doing this forever. Nobody's taken our epinephrine away from us. This is a study, 18,000 patient records over 14 years reviewed, plus an additional 5,000 records from the author's practice spanning 27 years in foot surgery patients. All were deemed healthy. Now that's one thing we have to look at, is what happens when, in the toes, when somebody's not healthy and they have a lot more ischemia. You're going to get a lot more ischemia in toes and probably fingers in general. But at least in the healthy folks, 65,000 surgical procedures reviewed that use lidocaine with epi, no complications due to the epinephrine. Literature review, 39 studies, epinephrine digital blocks in fingers and toes, no digital necrosis or gangrene in any patients. So I will say on this one's kind of interesting. I got a call from a lawyer because there was a lawsuit about somebody who'd lost a couple of toes, and they said, well, you talk about this stuff. What do you advise us? And it was a really fascinating story where a primary care physician had injected warts with Candida antigen. It's a treatment dermatologists sometimes do, and the patient had ended up getting a reaction and ended up getting probably a local vasculitis and ischemia, and lost 2 toes. But the lawsuit was that the doctor must have injected epinephrine by mistake. That's why it happened, even though there was a procedure note that said lidocaine alone, because, it was an internist. We're all scared of giving epinephrine, right? And the digit. So I was happy to give them an opinion that was BS. It was bad the person lost their toes, but it was probably a totally separate thing going on. Okay, I'm going to talk to you about a couple of myths of tradition. Some of those things where there isn't a lot of data out there, but there are sometimes advice that's given based on what might make sense. A 51-year-old man, status post-bowel surgery for diverticulitis 2 weeks ago, presents with pain and swelling the right leg and is found to have a DVT in the right femoral vein with the clot extending 20 inches. He has started on anticoagulation. What other recommendation is appropriate? So a person with a very large clot in a fairly big vein is found. We start anticoagulation. What else do we do? Put an IV filter in. Activity is tolerated. Bed rest for 3 days. Bed rest for 7 days. So how many people would do an IVC filter? Those things are evil. Activity is tolerated. Bed rest. Yeah, so how many of you when you were in training told that, the first couple of days people shouldn't be up and about and do that? Yeah, I was taught the same thing. And that was based on hey, there's a big clot there and you might dislodge it if you move and the muscles squeeze. It makes some sense, right? So yeah, somebody decided to look at that and say, hey, that's what I've been told. What do we know? It was a meta-analysis of 5 different studies looking at 3,000 patients, bed rest versus ambulation, not higher incidence of a new pulmonary embolus. And the patients who did early ambulation had a trend towards less PE and extension of DVT and lower mortality. Makes some sense. So yeah, it's been studied. So that's just one of those truisms that's not true. And you're all over that one. 58-year-old woman with a history of right breast cancer, status post-lumpectomy and lymph node dissection 5 years ago, presents for follow-up. Labs are ordered and left arm blood draw is attempted ×3 without success. What do you recommend now? So we need the blood, and we've been going after it here in the left arm. What do we do now? A left leg blood draw, a left neck blood draw, a left radial artery blood draw, or a right arm blood draw? So how many would do a left leg blood draw? Left neck blood draw? Yeah, nobody's letting you do that. How about doing an arterial puncture? How about going for the right arm? Yeah. Now the problem is going to be the patient's not going to let you do that. So we're going to go spend 10 minutes going, it's okay, I have data here. And they're going to still go, nope. I was told never touch my right arm. So where does that come from? Well, so lots of advice, sometimes from doctors, very commonly from nurses, from the American Cancer Society, all sorts of different areas will tell patients to avoid blood draws, injections, even blood pressures in the at-risk arm during and after breast cancer treatment, especially if they've had lymph node dissections. Although this advice tends to be that side, you're just not going to let anybody do anything with that arm. And because of concern that there's risk for lymphedema, risk for cellulitis, risk for all sorts of things, that's much higher than your other arm. This is from the ACS website last night. If the lymph nodes under your arm were treated as part of the treatments for cancer, some doctors recommend having blood drawn, IVs, and shots done in the unaffected arm if possible. Some also recommend getting flu shots and other vaccinations in the unaffected arm or somewhere else like the hip. So this is still pretty much out there. How about data? Do we have data? Has somebody studied this? The answer is yes. This is a study looking at patients undergoing treatment for breast cancer between 2005 and 2014. They were all screened for lymphedema, 3,000 measurements, no association with volume change or weight adjusted change increase, and undergoing one or more blood draws, injections, or blood pressure measurements. So they did questionnaires on all these patients on what happened to their affected arm, and many of them said nothing because I never let anybody there. And then there were women who said, no, I have blood draws, I have injections, and they then measured and looked at the arms and they found no difference. Another study, and some of the non-precautionary behaviors there, 251 of 2965 had one or more blood draws, 63 had one or more injections, 482 had one or more blood pressure measurements. Another study looked at patients over a 3-year period. 327 patients underwent bilateral breast cancer surgery, were prospectively screened for arm lymphedema, comprised 327 and 654 at-risk arms with immediate post-op follow-up that ranged from 6 to 68 months. Blood pressure readings, blood draws, injections were not associated with an increase in arm volumes in the cohort. So this doesn't appear to be something that we need to pull forward on advising patients. My feeling is if they've been entrenched in this and they're comfortable with that, I don't try to have them unlearn this because it takes too much time to try to explain that. But it also, people feel very strongly about it and they don't necessarily believe you. A lot of these older pieces of information that people hold so tightly, it's hard to dislodge. So, going forward, I don't advise patients on this, or if patients are bothered by it, or we run into a patient who can't get draws on one side, I'll say, I think it's super safe to do the other side, but you will run into some back push on this one. Okay, we're gonna move on into some everyday myths. A 74-year-old man with history of coronary disease presents to discuss his erectile dysfunction. He would like to have an effective therapy for his ED. He had an MI 4 years ago, stent placement without subsequent problems. He has had a 10-year history of angina with exertion, usually occurs predictably when he walks up a hill. Medications are atorvastatin, metoprolol, aspirin, and sublingual nitroglycerin that he has to use PRN. Blood pressure 130/80, pulse of 66. What do you recommend for him? Sildenafil, a vacuum device, alprostadil, testosterone, or refer him for a penile implant. So how many would recommend sildenafil? How about a vacuum device? How about alprostadil? How about testosterone? How about penile implant? Yeah, so this is a newer one, and I think the answer is A is perfectly okay. And, black box warning, the pharmacist might call you or say you do realize they're on nitroglycerin. I mean, you're going to get some pushback on it, but let's go through the data. And the first thing is it's PRN nitroglycerin, so you can certainly advise the patient that you don't take nitroglycerin if you have chest pain after you've taken your sildenafil, or you can say, here's an interval. But what if they just forget? What's going to happen to them? So, the first one was a case crossover study looking at the Danish health registry over a period of almost 20 years. And back in 2000, very early when sildenafil first was released, the rate of co-prescribing of any phosphodiester inhibitor in patients with ischemic heart disease in patients on nitrates was 0.9 per 100 persons years. And over the 20 years, it's raised up to almost 20 per 100 person years. So there's been a 20-fold increase in prescribing. And they looked at, has there been an increase in events or anything that could be attributable to this? And the answer was no. There was no statistically significant association found between co-prescription and nitrates with phosphodiesterase inhibitors and risk of MI, cardiac arrest, syncope, stroke, or adverse drug event. So even though it became a more common event to co-prescribe, they didn't see any real changes in their numbers. So that's a population study. I like this next one. I mean, these people were really brave to do this. I don't know how much they had to pay the people to get in this one, but randomized placebo-controlled crossover trial. Participants got a high dose of sildenafil, 100, or a placebo, then they get IV nitroglycerin. I mean, let's not just give them a sublingual, let's give it IV. Let's get those levels so high that they're going to have a horrible headache. So they did that, and the patients who got sildenafil had a 4 to 6 millimeter systolic blood pressure drop compared to placebo. There was no difference in severe events between the sildenafil and placebo groups. The blood levels of nitroglycerin were sky high compared to what people are going to get with the sublingual nitroglycerin. So this was helpful to see physiologically what happens when you maximize the drug interaction. You make sure this is as big a drug interaction as you possibly can get. Do they drop their blood pressure 10 points, 20 points, 30 points? Do people get hypotensive that need resuscitation? What happens to them? And they tolerate it well. Now, I will say, you don't get in this study if you have bad triple vessel coronary disease and 4 stents. You're not getting in that study. These people, I'm sure, are all healthy. So this is the physiology of nitroglycerin with a phosphodiesterase inhibitor in somebody healthy. But I think it gives us some information on the magnitude of types of blood pressure changes that you might see. So yes, I think most of you said sure they would prescribe it. I think we would still advise not to tempt fate by putting them together, but there's no reason to sort of say, well, my patient's so dumb that if I give them this and I advise them that they would automatically do it. And even if they do, they're probably going to be okay. Okay, a 55-year-old patient of yours requests new prescriptions from you at a routine appointment. She'll be traveling internationally next month and wants to replace her emergency medication kit as the medications in it, ciprofloxacin, loperamide, oxycodone, have all expired. What do? Replace the prescription for Cipro, replace all 3 medications, tell the patient that all the meds should still be fine. So how many people would replace the Cipro prescription only? How about all 3? How about tell them that meds should be fine? Yeah, well, that's convenient because it's always at the end of a visit when you've already gone 5 minutes. Oh, by the way, I'm traveling and I want all my meds refilled in my emergency medical kit. I hate emergency medical kits. I hate them because, like, what I really want is my patient to have a bunch of meds that I prescribed 25 years ago when I did everything wrong, sitting around and then just randomly taking when they feel an ache or pain. I mean, I hate them. But all that being said, the answer is C, because these meds are good probably for eternity. And we'll talk about some of the data on that. The other problem here is she has Cipro from like 2000 because it was a traveler's diarrhea med then. Now we don't like to do that because we are a little more respectful of Cipro and some of the things that can happen with it, and we don't think that it's worth it for traveler's diarrhea. So there are other issues. We probably aren't thrilled with people walking around with oxycodone. I had a patient one time who was a big mountain climber and he wanted his refill things because he goes, what if I break my ankle on the top of a mountain? I'm like, I'm feeling really good about you popping a couple of oxy on the top of a mountain somewhere. Yeah, that's really going to make sure you get down safely. So let's talk a little bit about expiration date on medications. And what's on there is it's a date that the FDA has talked to manufacturers, they need to guarantee 90% potency. And there's no magic number on when you choose for this date. And nobody looks to see when it drops under. It's just at 18 months or 2 years or 3 years after this lot has been made, we guarantee that there's 90% potency. That's their expiration date. So any guesses on who has the most skin in the game for financial loss when we have to toss a lot of drugs? It's kind of somebody you might not think of. It's the US military. So they have not only all the medications for our troops, but they also have to be sort of steward of all the meds that we have to keep for our population if we get a terrorist attack. And if any of you remember the whole anthrax scare, having meds so you can treat, 30 million people for that. So obviously, if you can extend shelf life by years, that's going to save a lot of money. So that's kind of the thought behind this study. So they commissioned this study, 122 drugs studied representing 3,005 lots, 88% with over 90% potency 1 year past expiration date, with the average extension being 5 years. Example, Cipro was in here 55 months with the average extension, Doxy 50 months with the average extension. And some of these, they didn't just keep going out 10, 20, 30 years. So maybe it's even better then. Well, yes. This is a really interesting study where they found some boxes of drugs from an old mom and pop pharmacy that had been in a back room for 28 to 40 years. It's a long time. And these were in like not a well climate controlled. They were just sort of like where you put all the stuff you don't want. And we all have those rooms in our house. Some of us, our whole houses are that, but you just kind of shove stuff and then, 30 years later you go, that's where the cat was, And so that's kind of like what this was. Anyway, so 12 of the 14 compounds tested were in concentrations over 90% of the labeled amount, 28 to 40 years. These were a lot of combo products, things like Fiorinol, Fioricet, where they had a barbiturate and they had a narcotic. And the only thing they found that really predictably broke down was aspirin. The aspirin was nowhere to be seen. The aspirin in these products was gone. It was less than 1%. But all of the other things in these combo products were fine for a very, very long time. Now, I get a lot of questions about epinephrine because EpiPens are expensive, and there have been several studies to look at, can you extend the shelf life of EpiPens? And yes, all the studies have looked okay on that. One study, they looked at that more than 2.5 years after expiration, the epinephrine was sterile and detectably pure at the same level as advertised. EpiPens less than 25 months past expiration contained at least 90% of labeled amount in another study. And the last study, they went to health professionals who had EpiPens stashed everywhere, in their car, in their cabin, no temperature control, anything, just EpiPens that they were like, I probably shouldn't use this. They go, well, give it to us. We're doing a study. Let's see what it is. And they found that all had over 80% of labeled concentrations, 1 to 50 months past expiration, and absolutely not cared well for. So what does this tell us? Well, I still get nervous with epinephrine. I want to make sure it works in my patients who have anaphylaxis, but I tell them that you can keep your other pens as emergency. Like if you want an EpiPen in every room of the house, like let's say you got your good EpiPen in your purse and you can't get to your purse because you're anaphylaxing in the kitchen. If you have one of your old expired ones in the kitchen, you might make it there. So I think the expired ones can have some role. I still want a person to have probably a good EpiPen. I'm not totally sold on this. They didn't show any of these used. These are just amounts, but it appears that this stuff doesn't break down rapidly. I've gotten questions on eye drops. There's very little data. People care about eye drops because if any of you have bought prescription eye drops recently, they are unbelievably expensive, so you don't want to be tossing them. The only study out there was a study looking at travoprost, and they found that up to 12 weeks after the expiration date, it was doing just as good a job as a newly opened bottle. So not really powerful data, but eye drops may be able to go a little past the expiration date. I've been asked recently about albuterol because people have inhalers that they use, once a decade. They have them in their house or whatever. And this is a recent study looking at active albuterol in expired lots. And they got albuterol solution and inhalers with expiration dates from 2001 to 2019. So some of these were almost 20 years old or more when they looked at it. And they found almost all lots of albuterol maintained over 90% product. The lowest they found was 73%, the highest 103%. Many of them were up to 20 years past expiration. So when your patient says, can I use my albuterol inhaler when it's past expiration? The answer is yes. And so it's another one of those ones where it's nice for them to have them in different places because they never know when they may have a very rare asthma attack. The last issue that comes up all the time is, okay, maybe these things work, but do drugs ever break down into things that will kill me? Do they become toxic or do anything bad? And certainly for the solid drugs out there, the answer is no. The only reported drug that's ever really done something bad was tetracycline, and the actual formulation that caused the Fanconi syndrome was taken off the market in the 1980s. So really, there's no toxicity. The only risk is lack of efficacy. And we don't think that's really true for most of these things. Okay, a 46-year-old man who lives in Tacoma, Washington is seen for fatigue. He has no significant past medical history. He is not taking any medications. His hemoglobin's 12, crit's 37, MCV is 103, TSH is 1.2. What workup do you recommend for him? So this 46-year-old who's got an MCV of 103, maybe he's a little bit anemic at 37. Do you get a B12 and folate, alcohol history, B12 and folate, alcohol history and B12 testing? So how many of you would do B12 folate? How about an alcohol history, B12 and folate? How about just alcohol history and B12? Yeah, I would not do the folate here. In 2023, we have an incredibly fortified supply of grains and other things that have folate. And so we see so little folate deficiency that it probably shouldn't be the first step of anybody with high MCD. I was certainly taught in medical school, B12 folate, it's somewhere in my brain stem. Someday when I'm gonna be in a nursing home incontinent, I'll still have that in my brain stem because it's been pounded in there. But we should unpound it. You know, we shouldn't just people just go MCV high, B12 folate, I'm done. When really most elevated MCVs are not B12 or folate, so we should think of it as a medical problem. So, you know, there's big change in 1998 when the fortification started to try to prevent neural tube defects. So we have a lot of folate in our blood now. Just to give you an idea how rare folate deficiency really is, this is a study looking at 2 teaching hospitals in Canada. 11 of 2,154 serum folates were low, and 4 out of 560 red blood cell folates were low. No subject with low folate could the anemia be attributed to folate deficiency. So they had over 2,000 folates done that really didn't help them with their diagnosis or treatment. Same thing from a bunch of Boston area hospitals, where 84,000 serum folate levels measured, and there were 47 deficient, and then, you know, none of these ended up contributing to the diagnosis. The Choosing Wisely campaign for the American Society of Clinical Pathology, don't ever order red blood cell folate levels. I suggest that we are cautious. We should not say never for regular folate levels, but we should probably not have it our first step of our workup. It should be our second or third step if we are still puzzled after we've done the rational things. What is a rational thing? Well, if you look at macrocytosis in the primary care setting, 300 consecutive primary care patients with MCVs over 100, 4.7% were anemic, 80% of the men, 35% of the women, the cause was alcohol. No cause was found in 6.8% of the men and 35% of the women. And almost all of the MCV elevations in non-anemic patients were due to alcohol. So no anemia with a little MCV elevation. Look at it more as, I need to do more of a drinking history. I don't need to get a folate or a B12 level. 29-year-old woman presents for evaluation. She reports that she has frequent headaches over the last 12 months that include pressure pain on her forehead, under her eyes, and over her cheeks. She usually has nasal congestion as well. She has not had any fevers or purulent nasal discharge. What is the most likely problem? So headaches for 12 months, pressure pain, forehead, under her eyes, and over her cheeks, some nasal congestion as well, no fevers or purulent nasal discharge. What is her likely diagnosis? Cluster headaches, migraine headaches, sinus headaches, or tension headaches. How many people think could be cluster? How about migraine headaches? How about sinus headaches? How about tension headaches? So this one is a variant of migraine headache, and it's a very common variant of migraines. And the myth here is that chronic sinus headaches exist, that sinus headaches certainly can happen when somebody gets a bad acute viral infection with horrible sinus inflammation with a bacterial sinusitis acutely, but the idea that 3 or 4 times a year I get a sinus headache doesn't make a lot of sense. And most of these people who have those recurrent things, probably 90% of them are migraine, variant of migraine. This is 3,000 patients screened with 6 headaches during the previous 6 months, self-diagnosed or physician-diagnosed sinus headache. 88% of them met international headaches criteria for migraine, with the symptoms being sinus pressure, sinus pain, and nasal congestion. So a lot of things that would make people think it's a sinus issue, where really it's migraine that is traveling down nerves that innervate sinuses. Another study gives exactly the same data. 100 patients recruited who thought they had sinus headaches, all got a physical exam and history and were diagnosed. And then again, mid-80s had sinus headaches, 52% migraine with or without aura, 23% probable migraine, chronic migraine medication overuse, and 11%. And the interesting one here was 76% of the migraine patients reported pain in the distribution of the second division of the trigeminal nerve, and 2/3 of them had bilateral forehead and maxillary pain. This is why people don't think of migraine here, because a lot of these people have bilateral symptoms, and we've been taught migraine tends to be unilateral. In this entity, it can certainly be bilateral. So that's one of the things that's gotten in the way of our diagnosis here. This is a study that shows how many years it takes to diagnose these people with migraine. They look patients with migraine with a past history of sinusitis diagnosis. 130 migraine patients recruited. Of these patients, 106 or 81% were misdiagnosed as sinusitis. The mean time delay to migraine diagnosis was 7.75 years with a range of 1 to 38 years. So a lot of these patients in our practices are kind of out there. And then this study was a treatment study. So they found a bunch of people who had sinus headaches and they studied them, did a good workup on them, and then treated them for migraine. And there were 54 patients enrolled, but they had a huge dropout rate. 16 of the patients dropped out. And what they did initially is they did a CT and they did nasal endoscopy. So they looked at the sinuses and they CT'd the sinuses, and they told the people, you have pristine sinuses, you qualify really well for our study. And 16 of them walked at that point saying, you are crap doctors, you don't understand sinus disease, you don't understand sinus headaches. So people have very strong feelings on this. But the brave 38 were treated, and they had 82% of them did really well with triptans, and 92% of them total did well with migraine-directed therapy. The people who didn't respond to triptans got other migraine-directed therapy, which helped them. Okay, a 59-year-old woman was admitted with abdominal pain. She has a history of pancreatitis. Contrast CT scan is ordered. She reports a history of severe shellfish allergy. When the radiology tech asks if she is checked, as she is checked in for the procedure, you are paged regarding what to do. So you order the contrast CT, and they're saying, hey, she's got a shellfish allergy. We're really nervous. What should we do? Do you tell them continue with the scan as ordered, switch to an MRI scan, switch to MRI with gadolinium, continue the CT with contrast, give a dose solumeterol, continue CT with contrast, give IV diphenhydramine. So how many want to tell the radiology tech continue with the scan as I ordered it? How about switch to an MRI? How about MRI and gadolinium? How about CT with a dose solumeterol? How about CT with the dose of IV diphenhydramine? So right answer here is continue with the scan as I ordered. I wouldn't add damn it at the end of it, but that's the right answer. So where did this come from? Well, fish and shellfish contain iodine, and allergic reactions to seafood are quite common, with a prevalence ranging anywhere from 2 to 6% of the population. And of course, iodinated contrast material contains iodine. So you can understand why people would put those together. Now, the problem is that the allergy to shellfish isn't due to iodine. It's due to proteins, parvalbumin and tropomyosin. So there are different proteins that cause this. It has nothing to do with iodine. So the idea that things from the sea are going to cross over to that. And plus iodine's present in all sorts of other things that we don't ask about. Now, what's really going on here is you have identified a group of allergic patients, and we always have that, right? The world's divided into no known drug allergies and 50, well, with a few people in between who might have 1 or 2, but it's kind of like some of us are just unlucky. We just react to everything, and other people you can give them anything. You can give them arsenic and they're fine, It just is the way the world is. And so when we get to do things where there might be allergic reactions, the seafood allergy people are kind of allergic people, but those are also the milk, eggs, chocolate allergy people, and the general allergy people, and the fruit allergy people, and the asthma people. All of those people are the same. They all have a higher risk of having a contrast reaction. So it seems silly that you worry about shellfish and you don't worry about any of these, because they're all going to have the same chance of having something happen. So what are our guidelines from the people who deal with all the time? And that's the American Academy of Allergy, Asthma, and Immunology and the American College of Radiology. So the American Academy of Allergy, Asthma, and Immunology doesn't recommend low or isoosmolar or radiocontrast media or pre-treatment with corticosteroids and antihistamines for patients with a history of seafood allergy. So they say just go for it if they have a history of seafood allergy. You don't need to do anything special. The American College of Radiology recommends pre-treatment with steroids only for patients who have a previous moderate to severe IV contrast reaction. So they will give They will give pre-treatment if they had trouble before. They won't do it based on allergy history. Okay, I just wanted to rail on colonoscopy dogma for a minute, because how many of you have had a colonoscopy? How many of you like the prep? Okay, so it doesn't have to be that bad. And why the gastroenterologists have known this for a while, and why some people still like to abuse us is beyond me. So, the dogma is clear liquid diet for 1 to 2 days before colonoscopy. You got to watch what you eat, a gallon to go lightly, and be absolutely miserable. That's kind of the standard thing for a long time. And there's all this data to say we don't have to do that to people. First thing is low residual diets versus clear liquid diet. A low residual diet is basically they're allowed meat, eggs, dairy, bread, rice through the day of colonoscopy. They can have all the ice cream they want. I mean, I can live off that for a couple of days. That's okay. And it's not miserable, not like the clear liquid diets. And so they randomized 200 patients to a low residual diet versus clear liquid diet. And the patients in the low residual diet group had better bowel prep than those in the clear liquid diet group, 81% versus 52%. So that was good p-value. And not surprisingly, they felt better, less nausea, less vomiting. Headache was less, weakness was less, and they were less hungry. So they were less miserable. They didn't do a misery index, but you could calculate it from all those symptoms if you want. Here's a meta-analysis of low residual diet versus clear liquid diet, comparable in regards to adequacy of bowel prep. Less nausea, vomiting, hunger, headache with low residual diet. Patients who follow residual diet showed an increased willingness to repeat it. Surprisingly, these people are easier to get the next colonoscopy on because we didn't make them miserable. Then we get into the whole issue of different bowel preps. There are many lower volume bowel preps now that you don't have to take in gallons of horrible stuff. There's Suprep, it's like 32 ounces, Movie Prep, Miralax plus Gatorade. There are several of these that have been studied, and they all are superior to Go Lightly for bowel cleansing. And patients who take these are more likely to complete the prep. That's why they work better. You get people that get into 3/4 of a jug of Go Lightly and they're like, oh, I'm clear, I can't do it anymore. So you get more adherence to the prep, so they work better. So we can let people eat. Low residual diets are tolerable with less symptoms and better outcomes. So why we do the clear liquid diets is beyond me. Go Lightly is a relic of the past, and in my opinion, really shouldn't be prescribed anymore. Okay, we're going to finish with a retired myth, and we'll see if it's still retired. But I put this out like some of the stuff like I was taught so dogmatically, I don't think mostly is done anymore, which is good. A 46-year-old man presents to the ED with severe abdominal pain. He states onset of pain was 2 hours ago, began suddenly in the epigastric area. He has not used any alcohol in the past 2 weeks, but has been on paroxetine for OA for the past 6 months. On your exam, he has a rigid abdomen without rebound tenderness. He is in severe pain. You call the surgeon and she'll be available to examine the patient in 20 minutes. So we got a guy who's in terrible pain with a rigid abdomen. What do? Give him IV morphine, give him IM Toradol, give him IV Demerol, no narcotics, wait for surgical evaluation. How many people would give him IV morphine? How about Toradol? How about Demerol? How about no narcotics, wait for surgical evaluation? So how many of you were taught that? That's out right out of Cope's, one of the early, at least the editions I read, right out of Cope's. It was like, you're going to mess everything up. You're going to make this guy so comfortable they won't be able to do a real good. And then they're going to take the wrong people to OR. That was what it was about. And this is from the version of Cope's I had. If morphine be given, it is possible for a patient to die happy in the belief that he is on the road to recovery. And in some cases, a medical attendant may for a time be induced to share that same elusive hope. Thank you, Dr. Cope. Okay, so there are several studies that were done in the 90s on this prospective double-blind placebo-controlled administration of morphine or saline in 71 patients with acute abdomens. No difference between the groups with accuracy of provisional or differential diagnosis. With final diagnosis, 3 diagnostic management areas in each group. Pain control was superior in the morphine group. Another 100 consecutive patients with severe abdominal pain admitted to surgical service. All patients evaluated by admitting officer, then half got saline, half got narcotics. Surgeons felt equally confident in diagnostic and management in both groups. Surgeons' decision to operate or observe was incorrect in 2 patients in the narcotic group and 9 in the saline group. So it certainly was not a problem to give narcotics. And I think this became became enough information that it really did change the approach. Really your patient who's in horrible pain with a perf or something, we can do pain control and we can still do good surgical management of these patients. Well, I will stop there, and I'm happy to try to answer any questions, or if people have favorite myths of theirs. I've researched about 40 of these, so I just had a little time for some of them, but happy to hear people's myths. I'm always looking for new myths to chase down as well.
Well, Dr. Powell, thank you very much for your outstanding talk. I would open it up to any questions here in the room.
Hi, thanks so much. Our medical team had a question about whether SCD use is mythical or not mythical. We were concerned that we are prescribing SCDs for our patients.
Compression devices?
Yeah.
Yeah. So there are a couple of older studies that show small benefit. But the problem is those studies were prior to some of the other things we do to try to prevent clot. Certainly around prior to low molecular weight heparin and some of those issues. So whether they add anything beyond that, I don't know.
Just a quick comment and a question, Doug. I would just want to comment on your professionalism for coming back to correct all these myths that I learned in 1989 from you.
Yes, thank you, Alex.
I think I heard a myth this summer when I was in Canada at a pharmacy, and they were giving away Narcan, so I got some from the pharmacist just to have on the block. And the pharmacist admonished me that it was that I had to keep this not in my car, and it couldn't get frozen, and it couldn't get too hot. Now, it was an IM form injection in a little vial, and I wonder if you know anything about Narcan, because that's going to be more prevalent, and I suspect we'll hear myths about that too.
Yeah, thanks, Alex. I don't know anything about Narcan. I do think when you look at the epinephrine piece, there is some data on that not being treated well, and it's still being okay. But I'll look into that.
Thanks. This is really fun. Maybe I'll make a quick comment about Dr. Hitchcock's question. My understanding of those SCD studies was that they showed efficacy, that is to say, under clinical trial conditions, but effectiveness was the problem. Most of these patients that we use them on aren't in clinical trial conditions, so you go in the room and the SCDs are draped over the bed, and obviously they will not be effective when they're draped over the bed. But my question is somewhat similar to Alex's. The one I was always anxious about prescribing if it was too close to the expiration date were oral contraceptive pills. And I wonder if you came across any data around OCPs.
I have not. Yeah, I just did a search 2 days ago, just try to see more on expired meds, because all these questions keep coming up. But I've had that one before, but I haven't seen anything on OCDs.
This was fabulous, and I'm going to admonish people in the room who are all good test takers, but I wonder if they were all honest about their answers. So I just saw a headline, so I've not read the article, but maybe a myth you can track down for us is colchicine for 6 months while you're up titrating allopurinol.
Yeah, I don't know. I don't know the data on that. I mean, the one gout myth was always that you couldn't start allopurinol for an acute event. And there's one nice study where they actually blasted people with colchicine, steroids, and allopurinol, and they found in that group they could start allopurinol as long as you were treating the inflammation initially, and then you kept those drugs for a month until you calmed everything down. But I don't know anything on how strong the evidence is about giving people colchicine long term, just kind of to bridge them or just keep them for a while.
Just wanting to make a comment about the SCD, compression stockings. I had a bad pneumonia, went on a medical an old medical school reunion 5 years ago, and ended up being admitted with a CO2, end-tidal CO2 of 103 because of a severe pneumonia, which I contracted. I was traveling alone, no partner, and trying to return a car to Manchester Airport. Couldn't find the airport, couldn't find anything. Ended up being pulled over by the police, and I was then unconscious for about 10 days in an ICU on a ventilator, nearly died. Now, to transport me back, they had to put me on an airplane, the KLM, the Dutch planes that came over to Portland. And it was going to take about 24 hours of travel. And they said, we haven't had you on compression stockings in hospital for the last 21 days, but you've been on heparin. You're not going to be able to get the heparin on board the plane, and you're going to be still. You're not going to be able to move around. So that's why we're putting you on the SCDs. So that was their logic. I got to Portland, of course, it was very snowy. It was Christmas, and of course, by then I was up and walking again, so I was fine. But that was the logic then from Harrogate Hospital ICU. That's why I got put on the stockings. They hurt.
You're here. Yeah, I mean, I just, the whole compression, I mean, I don't know how effective that is. I mean, patients don't like them, and they don't have an answer on how effective they are. And again, as you layer them into other therapies, how must-have they are.
I wanted to make one more comment, totally separate. That was the basis of the whole colloid versus crystalloid argument. Anesthesiologist that I got involved in. It was nothing to do with whether colloid and crystalloid were better. It was because every submarine or every piece of naval equipment, army equipment, had a renewable bag for 5% aluminum. A lot cheaper to use lactating rings. So that the argument raged that way. Really, it was the difference in cost. One was $50, the other one was 84 cents.
Yeah, well, unfortunately, money makes the world go round, and that's part of a lot of our ills.
Great. Thank you so much for your comments, and particularly for bringing in the patient perspective, which certainly weighs heavily in this discussion of medical myths. Dr. Pao, thank you for helping us dispel some dogma, and many questions remain. Thank you to Dr. Cleven and the Portland Clinic for today's lectureship.